thin descending loop of Henle permeable to water. Then there is thin ascending loop of Henle and thick ascending loop of Henle. Both are impermeable to water and they reabsorb 25% of sodium chloride, then 15% of water, then 20% of calcium and 10% of bicarbonate. This is about loop of Henle. Now, try to understand how much is the GFR? 180 liter per minute or per day? Per day. How much is per minute? 125 ml per minute. So, 125 ml per minute is the GFR or 180 liter per day is the GFR. But the urine formation is how much? Yes, 1 ml per minute only or 1.5 liter per day. Yes or no? So, it means maximum water is reabsorbed. So, you can see here in the medulla, maximum water is reabsorbed. So, in which condition there can be so much amount of water reabsorption? Your medulla should be hyperosmolar or it should be hypoosmolar. That's very common sense that so much of water reabsorption can happen only if our medulla is hyperosmolar. So, to reabsorb the water, to maintain water balance, for this homeostasis, you need medullary hyperosmolarity. This is clear? Now, there are two different type of questions in your examination. This medullary hyperosmolarity is created by who create this and maintained by, both are different question. Question number 1. See, if there would not have been medullary hyperosmolarity, there would not have been water absorption. Water absorption is possible only because your medulla are hyperosmolar. So, who is creating this for us and who is maintaining this? It should not be deviated. It should not be vanished. So, if they ask you who create medullary hyperosmolarity, answer is countercurrent multiplier by sodium potassium 2 chloride and by urea recycling, and both are happening in the loop of Henle. So, medullary hyperosmolarity is created by countercurrent multiplier. Remember that it is multiplier. And who is maintaining this medullary hyperosmolarity? Then answer will be countercurrent exchanger, and both combined together is called as countercurrent mechanism. So, multiplier and exchanger combined together called as, it is called as countercurrent mechanism. It is a whole long question. Sometimes they ask you short note, but this is very, very important. Okay. So, point number 1, countercurrent multiplier. What is countercurrent multiplier? Now, see, for example, if plasma is filtered, osmolarity remains same or different? It remains same. What is normal osmolarity? It is 285 to 295. Let me assume 300 milliosmol per liter. Suppose 300 everywhere. Everywhere is 300. So, when the plasma is filtered for the first time, it is 300 milliosmol per liter. Yes or no? Yes. And when it passes through the PCT, osmolarity remains same or changes? Same, I have told you already, because of the solvent drag. Water is also coming because of the osmosis. So, the concentration remains same, and water is reabsorbed by which aquaporin? 1. You know this from PCT. Okay. Now, it keep on coming in the loop of Henle, descending, then ascending, and then in the thick ascending loop of Henle, there is a hero. Which hero? NK-CC channel. Sodium, potassium, 2 chloride channel. So, everywhere there is 300, 300, 300, 300, 300 in TAL. See, whenever I say TAL, it is always thick. Okay. So, in TAL, NK-CC will absorb sodium chloride and increase the osmolarity of the medulla. So, now in the medulla, it become, suppose there is 300, 300, 300, it become 400, and in the tubule, it remain 200. It's very understood. 300 everywhere. When it reaches the TAL, 300 is there, 300 is there, but if you reabsorb sodium, it become 400, it remain only 200 because combination is 600. Either 300, 300 or it can be 400, 200. Now, descending loop of Henle is water permeable, having osmolarity of 300, but outside is 400. Now, it start losing the water. Outside is 300. So, by losing the water, it will also become 400. Outside is 400 now. Initially it was 300, now it become 400. So it will lose the water to become how much again? 400. Now this 400 will start triggering to the loop of Henle, will go to the TAL. So now in the TAL 400, in the medulla it is 400. But again your sodium potassium chloride channel will work. And from 400 it will become 600, and this will remain 200 again. 448, if it becomes 6, it will remain 2 only. So now medulla has 600 osmolarity. Now again in the descending part it is 400, outward 600. It want to lose the water to become more concentrated. Now it will also become 600. Loop of Henle will have 600 now. 600, 600, 600. Now it will again reach the thick ascending loop of Henle with the 600. In the TAL it is 600, in the medulla it is 600, but